Good afternoon, welcome to Grand Rapids today. As always, please remember to sign the attendance record, and also please remember to fill out the program evaluations picked up on the Voting Center. And most importantly, fill out the requests that you might have for future topics, future speakers. Today, I have the pleasure of actually reintroducing Geoffrey. As you may recall from previous excellent backgrounds, presentations he's given us here, he holds a Dr. Pharmacy degree, and currently is a professor of clinical services at Drake. He's the director of the Drake University Drug Information Center. He's adjunct clinical associate professor at the University of Iowa. He's associate professor of pharmacy faculty at Drake, and he also is the internal medicine clinical pharmacist at Iowa Methodist. And he kindly has accepted our invitation to his own today to provide us with an update on Gamechangers in Pharmacy and Medicine 2018. And please join me in welcoming Geoffrey.
Thank you very much. Hope everyone can hear me. I have a loud enough voice. People usually don't complain about not hearing me. So we have a ton of slides to get through, so I'm probably going to kind of skip some of the niceties because we just got there's tons of information, and I actually got asked to do kind of a pickup topic too. So we're just going to dive right into things. As you saw in the previous slides, here are my disclosures, and I will be discussing off-label information. The objectives for Gamechangers are always very general because we're talking about such disparate things that it's difficult to kind of rein things in one set of learning objectives. But what I really hope, though, is at the end of Gamechangers that you're able to take one or two pearls back to your own practice and take a look at it and try and look at an evidence-based way to impact and implement some of these pearls into your own practice and maybe answer some questions that you've had about some of the new things coming out in the last year or so. So Gamechangers are facets of clinical medicine that directly affect boots-on-the-ground clinicians. Some are really specific to practice site. Others are more general in scope. Since I have a lot of prescribers in the audience, a lot of it is based on whether you're a primary care provider, whether you're a hospitalist versus an ambulist. There's always some different things that are coming out depending on what it is. Here are some examples of the Gamechangers, and I won't read them to you, but I think we have a pretty good idea of what we're talking about when we talk about Gamechangers. The problem with Gamechangers is that it's always hard, at least in my world, to say, what is a game changer that's going to impact the highest number of people? Because what I might think is a game changer to one of my colleagues in community pharmacy may say, well, yeah, I don't ever deal with that, so it doesn't matter to me, And in the medical world, if you're a subspecialist, this is something that may really impact you, whereas the primary care doctor may say, well, I'm never going to prescribe that drug, or I'm never going to do that test, so I don't really care. So trying to come up with kind of a general set of guidelines and Gamechangers that are going to impact the highest number of people is something that we really struggle to do. How we've solved it in this talk that I give every year to the Iowa Pharmacy Association Expo meeting is we develop a Gamechanger panel. So we actually have representatives from hospital, community, long-term care, pharmacy, and then we have oversight by a pharmacist with expertise in regulatory affairs. And what we do is all of us, we independently select what we think are Gamechangers in our areas. Then we meet and do a modified Delphi method to kind of spin things down into the 8 or 9 Gamechangers we think are going to have the biggest impact to the profession as a whole. What I've done for this talk is taken out the stuff that is super pharmacy centric, because again, that will probably not, many of the prescribers are going to be like, yeah, I don't care about that, and try to focus on stuff that is going to be really kind of primary care focused and things that will impact the widest number of prescribers. So here's the Gamechanger panel. I always like to thank them because they do a lot of hard work for zero money and a lot of time to pick out the Gamechangers and need to do stuff. So there's some ground rules I always have. Your Gamechanger, you say, why didn't we talk about that? Well, we just may not have had time to include it, or it didn't make the final cut. We try to be up to date, but this is always, it's a couple months out of date, so keep that in mind. We don't have all the answers in controversial areas, and we're not listed in perceived order of importance. So with that, we're going to go right into it, because like I said, we got a lot of stuff to talk about. So our first Gamechanger is the 2018 Infectious Disease Society of America guidelines for C. diff disease, and I will not make any poop jokes, especially as you guys are eating lunch. So why did the IDSA decide that we needed new guidelines? Well, I don't know about Mary Greeley at Methodist, and I think most of the Unity Point hospitals in Des Moines, our C. diff levels have actually leveled off in the last couple of years. We were going up, I think, all throughout the early 2000s, and I think since about 2012, local controls, just washing hands, things like that, have really leveled off locally. However, we all still run into patients with C. diff infections. Some are minor, some can be very, very severe. And the sad fact is with C. diff is that if you get C. diff colitis, 20% of those patients are going to get a recurrence. And if you get a first recurrence, 50% of those patients after will get another recurrence and another recurrence and another recurrence. So it's still an important disease state, and since the last set of guidelines had come out, several papers had come out that had the potential to change what we consider the standard of care. Like most standard guidelines, how they did it is they brought an expert panel together. They used the PICO format to basically ask and answer clinical questions. They then did a systematic review to look at the literature and then label the literature as either strong level of evidence, moderate level of evidence, or low level of evidence based on the strength of the data, and then also things like safety, efficacy, and cost. It should be noted that most of these recommendations don't have a strong recommendation simply because there aren't really good, strong randomized controlled trials in a lot of these areas. So what do they call a case definition of C. diff? It's the presence of diarrhea, almost always watery diarrhea, or evidence of megacolon and severe ileus, plus either a positive laboratory test or evidence of pseudomembranes, right? They do note that there are certain people who are at high risk for developing recurrences and high risk for death from C. diff, and that includes patients over age 75, patients with inflammatory bowel disease, transplant patients, cancer patients, and chronic kidney disease patients. All are at higher risk for complications from C. diff. They also talk about antibiotics, and the sad fact is all antibiotics are associated with C. diff. Even the drugs that treat C. diff have reports in the literature of them causing C. diff. So just kind of keep that in mind. But they do note that the highest or worst offenders are the later generation cephalosporins, the fluoroquinolones, carbapenems, and clindamycin. And it is worth noting that none of those are really higher than another. They all have about the same risk for causing Clostridium difficile. So how do you diagnose? And I don't know how things are done here at Methodist. We had kind of a big change in the last several years how we approach this. The first is we try to tell people don't test unless you have 3 watery stools in 24 hours. So if you don't just test just to see if the patient may be colonized with C. diff. And then what the guidelines say is that to get the highest level of sensitivity and specificity, you want to use 2 tests. One test is going to be some sort of test like PCR that's actually going to look for the presence of the organism in the stool, and then another test to look for the toxin, right? So because remember, it's the toxin that causes the problems with C. diff. And so at Methodist, what we do is we have a film array, we have a stool film array. That's often what's done when people have watery diarrhea. If that comes back positive, what that means is the patient is colonized with C. diff, and then it'll automatically reflex to doing an EIA to look for the stool. And if the patient has a negative EIA and doesn't have high risk, we probably won't treat even if the C. diff PCR is positive. What it means is they're colonized, but they don't necessarily have active infection. If they're super sick or super immunosuppressed, we often do treat even with just the positive PCR just to be on the safe side. Don't perform repeat testing within a week in the same episode. Really, if they get better, you know they've basically been cured. And so that's something to kind of keep in mind. They do talk about how important infection control is. And then they do talk a little bit about the fact that there is at least some data to suggest that soap and water is the best way to clean your hands after examining a patient with C. diff as opposed to alcohol-based hand gels. However, they do also mention that in many areas that it's difficult to get people to do that because washing hands with soap and water takes more time. And they do say that hand gels are better than nothing, but that soap and water is probably preferred. Then they talk a little bit about, should you be scoring your patients to determine, what's their risk of recurrence, what's the risk of morbidity and mortality with C. diff. There's a number of scores out there. This is probably the most common one, the Atlas score, that takes a look at a number of things like, their albumin, their serum creatinine, temperature, things like that, and then adds points together. I'm not going to spend a lot of time talking about that because actually the IDSA comes right out in their guidelines and says we don't recommend any one severity scoring system. So they basically just say, take a look at the patient. They're either really sick, hemodynamically unstable in the ICU, or they're not quite so sick and either on the floor or being treated as an outpatient. So then how do we treat that? First and most important thing, pearl takeaway, Flagyl is gone. Bye-bye. No more Flagyl for C. diff, right? So that is now considered, unless you're in a low resource area, to not use Flagyl for the treatment of C. diff. So the first episode is now oral vancomycin, 125 POQID, and note the dose. You don't have to blast people with 500 milligrams. You're just adding more cost to the treatment without any more benefit. Or fidaxomicin, 200 milligrams twice daily for 10 days. So those are the first recommendation. For patients who are really sick, so hypotension, shock, ileus, or megacolon, almost certainly going to be treated in the ICU. They do recommend a higher dose of oral vancomycin, 500 milligrams 4 times a day, or 500 milligrams given per rectum every 6 hours as a retention enema, which I can tell you as a pharmacist is just about as much fun to make as I'm sure it is to give to the patient. And plus IV metronidazole 500 milligrams Q8. So you do use the two together in patients with fulminant disease. Remember, about 20% of these patients are going to have a recurrence. If they have one recurrence, then the treatment is usually recommended to be a pulsed vancomycin, or basically a vancomycin taper over about 6 weeks. You start off with the regular dose and then slowly taper them off to 3 times a day, 2 times a day, once a day, and then every 2 or 3 days. And the theory behind that is that it will also take care of the sporulating forms of the C. diff, and those are the ones that aren't usually affected by antibiotics because they're protected against it. Or if the patient doesn't want to be on vancomycin, or you've already tried vancomycin, you consider fidaxomicin as well. If they have more than one recurrence, so they've gone to the second recurrence, basically they come right out and say go right to stool transplant. So stool transplant is now really gone way up in the guidelines as far as the treatment is concerned. More than one recurrence, you should, if you're in an area where you can do it, you should probably go to FMT. Now that being said, these guidelines came out, and many of you probably read in the last 2 or 3 months, we've actually had our first death because of a stool transplant. That they actually had a perf from a colonoscopy, and the patient actually died from it. So I don't know if the FDA is going to be quite as hands-off about stool transplant as they have been previously. It'll be interesting to see what happens from that. But again, stool transplants is what they recommend first line, or if they haven't already had a tapered vanco regimen, to try that, plus a rifaximin chaser. So you'd actually do the tapered vancomycin and then do rifaximin for 20 days or fidaxomicin. That's basically all they recommend as far as treatment is concerned. If you have greater than one recurrence, this is basically what you go to. They don't talk about prophylaxis. So what if you had a patient who had C. diff 2 months ago and now comes into your hospital with a urinary tract infection, and you're like, ooh, I got to get this guy on antibiotics, but he just had C. diff 2 months ago. They don't really talk about it, but there is one study that was published a couple of years ago that suggested that 125 POB ID of vancomycin while the patient is on other antibiotics is a reasonable way to prevent a recurrence. They don't talk about probiotics for C. diff, which is a question I get asked all the time. Is there any data about probiotics and C. diff? I think the balance of the data that I've read suggests that it doesn't have a role in the treatment of C. diff, but it might help in protecting it against the patients who have had one recurrence. It's probably not a bad idea to put them on probiotics as long as they're not massively immunosuppressed. And then there's been numerous studies that have suggested that proton pump inhibitors are associated with C. diff and with recurrence. And there's actually a paper that came out a couple of years ago that looked at risk factors of recurrence and actually found that being on a proton pump inhibitor is actually a risk factor for recurrence. So in my hospital, what we basically say is that unless you've just had a GI bleed or you have some reason that you absolutely have to be on a proton pump inhibitor while you're being treated for C. diff, we can switch you down to even an H2 blocker during the treatment. That's what we usually recommend. So what are some treatment pearls to walk away from? Don't forget cost. Oral vancomycin capsules are incredibly expensive, even now, $1,000 for about 2 weeks for them. A commercially available liquid was given FDA approval last year, and many community pharmacies are now carrying it. It's about $200 for a commercially available liquid, so it's not terrible. It's not cheap either. 10 days of fidaxomicin is $3,000, so it's an incredibly expensive drug too. The reps assure me that there's plenty of patient assistance programs. Okay, well, good luck with that. And then if you add the chaser of fidaxomicin onto that, it's $1,500. But FMT isn't cheap either. The average cost of a fecal transplant is $3,000. And as you might imagine, the ick factor is actually pretty high with that, even given it by colonoscopy, which is what is usually done, at least around here. As you might imagine, many patients aren't jumping up and down to do this. However, a new formulation of stool transplant in the form of freeze-dried encapsulated stool, so basically stool capsules that are encapsulated and supposedly don't have any taste, will probably be available later on in 2019. You do have to take like 2 big handfuls of it, so I'm not sure, again, I'd be jumping up and down to do that, but it is a potential for patients who don't want to go through the regular route of FMT. Cost of recurrence is expensive too, so the bottom line is this is an expensive disease to treat. It's an expensive disease when you have a recurrence. While we're on the subject of antibiotics, the FDA has come down in the last couple of years saying we really need to talk about the side effects associated with fluoroquinolones. And there's been numerous label changes in the last, just even in the last year, as far as safety warnings with fluoroquinolones. There's a strengthened warning about hypoglycemia, which we have seen in my hospital. There's new warnings about CNS adverse effects such as memory impairment, agitation, delirium. And then, as you may have seen just in the last couple of months, even was so hot off the press that I didn't have a chance to update these slides. A couple of months ago, there was a warning from the FDA about aneurysmal rupture in patients with quinolones. I'm like, really? That too? So the bottom line is that the FDA has come out with a couple of Dear Doctor letters in the last couple of years saying, please try to not use fluoroquinolone antibiotics for common infections such as sinusitis, or uncomplicated urinary tract infections. The problem I have with that is that they should have come out with that warning 20 years ago. I mean, where, you know, the Cadillac has been stolen quite a while ago. You know, yes, we probably should have not been prescribing quinolone so heavily, you know, like I said, 20 years ago. My docs, I think, are getting pretty good about not using these drugs unless we absolutely have to. But again, I think we still reach for these medications when other medications could certainly fit the bill. That's Gamechanger 1. Gamechanger 2, the update on the use of aspirin to prevent vascular disease. There's been a lot of movement on this topic in the last 18 months, and unfortunately, after you read all these studies, you may need an aspirin for the headache it's going to give you. So, you know, despite a lot of the advances we've made, cardiovascular disease, of course, is still the leading cause of death among Americans. And depending on where you live, the rates can be very high in the so-called stroke belt in the southeastern United States. That's where the rates are highest. Iowa's kind of in the low end range, which is a good thing, but it's still a leading cause of death and morbidity throughout the United States. And one of the biggest risk factors, of course, in patients with cardiovascular disease is diabetes, right? So we know that patients who have type 2 diabetes, their risk of having a cardiovascular event is increased 2 to 4-fold. And that for many, many years, because of that, aspirin was recommended for primary prevention in patients with type 2 diabetes. Basically, if you had type 2 diabetes, by definition, your risk of cardiovascular disease was high enough that you should probably be on an aspirin a day. And that was based on some primary prevention studies that looked at diabetic subgroups, but they were really kind of limited because they were just subgroups from other studies. Also, that comes in the question is, how long do I keep my patient on aspirin? They're 95 years old. Do I still need to have them on a baby aspirin a day, right? And in 2016, the U.S. Preventative Services Task Force actually released a white paper on this and basically said that really the best and highest benefit you're going to see with primary prevention with aspirin is in patients ages 50 to 59, because in that age group, you prevent 225 non-fatal MIs and 84 non-fatal strokes per 10,000 men treated, with a net gain of 333 life years. And similar findings were noted in women, but they also noted that that people got past age 60, the rise of harm begins to rise and the rise of benefit starts to slowly drop. And so the benefit risk starts to not become quite so clear. So before we get into these studies, I do want to point out that I am certainly not talking about secondary prevention. Once you've had a heart attack or stroke, you should be on antiplatelet agents if you can possibly be on them. It's been well established over dozens of studies, so we won't belabor that. But this does bring up the point of primary prevention. The data with primary prevention is really much less clear than that the benefit outweighs the risk, particularly in GI bleeding. And in 12 months, actually within about 3 months, 3 rapid studies came out pretty much in succession that tried to help clear this conundrum. The first in patients who have known moderate cardiovascular risk factors but not known cardiovascular disease, in patients with diabetes without known cardiovascular disease, and then in patients over age 75. That first study was the ARRIVE study. And these are all fairly similar studies. They're randomized, double-blind, placebo-controlled, big studies, international studies. This was 12,000 patients. And in the ARRIVE study, they included patients basically at moderate risk for cardiovascular disease, men over age 55, women over age 60 with 3+ cardiovascular risk factors, which they included as hyperlipidemia, hypertension, smoking, or positive family history. And they could be on treatment for those risk factors. They excluded people who had known cardiovascular disease, who had diabetes, and who were on antiplatelets or anticoagulants for another reason. The intervention in the study was 100 milligrams of aspirin daily or placebo. You may ask why 100 milligrams, because the study was done in Europe where they do have 100 milligram aspirin tablets, although we don't have them here. And the mean follow-up was 5 years. So again, I think a long enough follow-up to figure out if there was a benefit here. Like all cardiovascular studies, they used one gigantic MACE outcome, major adverse cardiac event outcome, which included about 5 different other things, including myocardial infarction, stroke, unstable angina, cardiovascular death, and TIA. And then they also looked at safety outcomes, primarily GI bleeding, using the Gusto criteria. As far as baseline characteristics, most patients were male, about a quarter were smokers. Mean systolic blood pressure on entry was high, about 145, and their mean Framingham score was above 10%. Their mean Framingham score was about 14%. So again, these were people we would consider to have moderate to high risk for cardiovascular disease. And what they found is nothing. It didn't do anything. There was no difference in any efficacy outcome between aspirin and placebo in these patients. But they did find a statistically significant increase in gastrointestinal bleeding. So there was no difference in efficacy, and the number needed to harm was 197. So you didn't benefit anybody, but about every 200 patients you put on aspirin are going to have a GI bleed from it. Strike one. The ASPREE study was a randomized placebo-controlled trial to determine if aspirin in healthy community-dwelling older adults with prolonged healthy lifespan free from dementia and persistent physical disability. So in other words, if I have older patients and they are fairly healthy and they live in the community and they're independent, is putting them on an aspirin a day going to benefit them just in general? This is done primarily in Australia and the United States in patients over age 70 or over age 65, in patients who are African American or Hispanic without dementia or serious physical disability. So again, fairly healthy adults. They excluded known diseases that would limit lifespan to less than 5 years. And again, anyone who had a known cardiovascular disease or stroke history. Same intervention at 100 milligrams a day of aspirin or placebo. And they ended the trial at about 5 years with about 20 patients. It was an endpoint-driven trial, so they stopped after they had enough endpoints. About 19,000 patients in the study. Their outcomes for efficacy, disability-free survival and death from any cause, and their outcomes for safety, major bleeds. They also stratified the data in numerous ways, height, weight, other factors as well. As far as the baseline, about half of them were male. Over half of them were over age 75. About 3/4 of them had hypertension. They weren't very big patients. BMI mean was 28.1. And the percentage considered frail, so in other words, those who were at high risk for falls and things, was fairly high as well. And again, they didn't find anything. There was no difference in the primary outcome or any secondary outcome in patients who had aspirin, placebo, and in older adults who are community dwellers. But again, they did find an increase in major bleed of 3.8% versus 2.8%, which was a number needed to harm of 100. And there was no difference in death from any cause in this trial. So, strike two. And then we have finally the ASCEND study, which is a randomized double-blind placebo-controlled study done in the United Kingdom of about 15,000 patients. And this was a study, again, looking at diabetics without known cardiovascular disease. So anyone with diabetes over age 40 who did not have known cardiovascular disease and did not have another indication to be on antiplatelets or anticoagulants. Another 5-year study. It was actually a 2x2 factorial design because in addition to looking at aspirin a day, they also wanted to look at omega-3 fatty acids. Would omega-3 fatty acids help diabetics? And that has not been reported as of yet. Mean follow-up was 7.4 years, so a fairly long study. Outcomes, the primary outcome was a serious vascular event, which was defined as a composite of an MI, stroke, death from a vascular cause or TIA, and then the safety was major bleeding. Baseline characteristics, 60% male, average age about 63, BMI is a little more what we would expect to see in this population, about 30, and 3/4 were on statin use. So again, many of these patients had hyperlipidemia and were being treated for it. This time they at least found a benefit, right? So when they took a look at overall benefits, they did find that aspirin did reduce serious vascular events in these patients by 12%. Unfortunately, it also increased the risk of major bleed by 29%. So you end up with a number needed to treat of 91 and a number needed to harm of 111. So the benefits are very, very close to outweighing the risks here. And while we're on the subject, you may have read or heard about a paper that said, hey, we're not using the right dose of aspirin in obese patients. So this garnered a lot of lay media attention. There was stuff on the Today Show about it and all that. It was a patient, it was actually a review study. So it was a patient data level review where they looked at the use of aspirin again for primary prevention. And what they did in this study is they looked at a whole bunch of trials that it had more than 1,000 participants who were on daily or alternate day aspirin versus no aspirin at all. And they wanted to take a look to see if there was any benefit, if there was any interaction on weight and the benefit of aspirin. And in the study, they did find that. They found that low dose 81 milligram aspirin is effective only in patients up to 70 kilograms, while higher doses were effective only in patients from 70 kilograms and above. This study doesn't make any sense from a pharmacologic standpoint because we know that platelets are blocked by aspirin at incredibly low doses, 20 milligrams, 25 milligrams. So this study is a retrospective study that it's not a randomized controlled trial that shows this. I would not use this information to switch obese patients to high-dose aspirin based on this information. And I've gotten that question a few times. Hey, I saw this. Do I need to do this? No. I say the same thing to my physicians I've been saying for the last 20 years. There's really only 2 or 3 reasons to be on full-dose aspirin. Acute MI, acute stroke, and that's about all I can think of. Everybody else is on a baby aspirin. There's no reason to be on higher-dose aspirin. It just increases the risk of GI bleed. So what's it all mean? I'm not saying don't put your patients who've had heart attacks or strokes on aspirin. You absolutely should do that if they can tolerate it because it's unequivocally beneficial. But millions of Americans take aspirin a day because they see television shows telling them to take it, they see commercials, and many healthcare providers say, yeah, I think an aspirin is good for most people. Really, in many cases, the data is not suggesting that's true. It's suggesting there is no benefit and perhaps harm in doing so. For the pharmacists in the room, I think our role in particular when they're asking to take aspirin over the counter is to say, gee, do you have a cardiovascular risk? And to remind patients that aspirin is certainly not innocuous. Next game changer. The numbers don't line up because I pulled out some game changers. The 2018 ADA EASD guidelines for the treatment of type 2 diabetes. So some big changes in the treatment of type 2 diabetes. And it's a good thing because we now have studies that with newer drugs that show that there may be some improved macrovascular outcomes, but they may come at a cost. So as many of you know, I guess if you're a researcher or researching drugs for diabetes, it's probably a good time to do what you do for a living, because we've gone from 1920 to 2015, and all we've seen is a dramatic increase in the number of types of drugs for type 1 and type 2 diabetes. And so we started way back in 1920 with regular insulin, and now we're entering the second decade of the 21st century, and now we have a wide variety of different types of drugs to use for type 1 and type 2 diabetes. And here's just kind of a quick overview of how we've kind of approached this, right? So we can approach things by improving glucose production in the liver. That's kind of what metformin does, or acts as a secretagogue. That's obviously what insulin and sulfonylureas do. We can have some effect on sensitivity. That's kind of what the TCDs do. But really what we've really focused on in the last 10 years is primarily drugs that either work on incretin, and we'll talk about that in just a second, or drugs that increase glucose reabsorption in the tubule as the urine is being excreted. And so incretin is an interesting molecule. So incretin is a second messenger molecule that is released when the body eats, right? So when you're finishing your lunch, your body is even now probably releasing incretin, telling your pancreas, hey, he just had salad and a couple cookies. You better give me some extra insulin to cover that. And that's what it does. However, we in the last 15 years have also learned that incretin does a number of other things as well. It actually enhances glucose-dependent insulin secretion. It reduces hepatic glucose output. It decreases postprandial glucose secretion, and it may contribute to the feeling of feeling full. So it may actually work on making people say, hey, I don't need to eat anymore when incretin is being excreted. Unfortunately, type 2 diabetics, incretin levels are usually blunted. They're usually low or below normal. And so this has been a natural target for pharmacologists to come up with ways to treat type 2 diabetes. And those ways are either the DPP-4 inhibitors, which are drugs that block the natural degradation of incretin. And those are the gliptans, right? So sitagliptin, et cetera. Or the GLP-1 receptor agonists, which are drugs that are incretin mimetics. We can't give people incretin because it lasts about 2 seconds in the body. It has a very short half-life. So we give drugs that are like incretin with much longer half-lives, and those are the injectable GLP-1 drugs that include, Victoza and all the other injectable GLP-1 drugs. So how do they work as far as decreasing hemoglobin A1C? Well, the DPP-4 inhibitors aren't terrific drugs, about 0.5 to 1% reduction in A1C. You might get a little more of GLP-1 drugs. As far as weight, we know that the GLP-1 drugs are usually associated with a small weight decrease, and some people a lot of weight decrease. That's why they're actually FDA approved for that. They also have some nausea associated with it, which I've always wondered if that contributes to the weight loss. If you're nauseated, you're not eating. And cost. We do have a generic DPP-4 drug out, which is helpful, but it'll be a good long time before the GLP-1 drugs come out as generic. So they're pretty pricey medications, anywhere from $300 to $500 a month. So, if you talk to endocrinologists and, other experts, they say, well, how do you approach this then? Well, certainly insulin is going to have a role, right? And in patients who have very high hemoglobin A1Cs, with most of the medications we have, if hemoglobin A1C is above 10%, unless they really have some significant lifestyle changes, it's going to be difficult to get them under control with just oral agents. That being said, if they're in the kind of 1 to 2% raised and you want to use an incretin option, a GLP-1 drug certainly makes sense, whereas less than 1%, you could probably use a DPP-4 drug. And then insulins, we use more and more basal insulin. Unfortunately, it's become unbelievably expensive, as many of you know, and treating many of these patients, especially as they have very high hemoglobin A1Cs. The other area that's been a real target for pharmacologists has been glucose reabsorption in the kidney, right? We know that about 90% of glucose is actually excreted from the proximal tubule from the glomerulus into the proximal tubule, but most of that is reabsorbed back into the bloodstream at the SGL2 site. So some smart apple said, hey, well, why don't we just block that, and you'll keep most of that sugar in your urine, and you'll just pee it out. And that's exactly what happens. So you get glucoseuria, loss of calories. If you talk to the reps who push these medications, they say, well, what they are told to say is that you pee out about 500 kilocalories a day if you're on these medications. So because of that, we've had this explosion of new drugs approved for type 2 diabetes. But the FDA has been got pretty leery, and I think they should have, with the TZD debacle. So those of you who are more veteran prescribers might remember rosiglitazone. Remember, rosiglitazone was one of the TZD drugs that came out, and a lot of people were on it, and then the FDA pulled it from the market because post-marketing studies suggested an increase in myocardial infarctions. And it didn't help that 10 years later they said, oh, we were just kidding, we're going to remove that, you can be on it again, like anybody's going to be on that drug now. But what the FDA, I think, learned from that was that they wanted to have cardiovascular outcome studies with these drugs. And so they have now mandated since 2015 that all drugs that are going to be approved for type 2 diabetes have to have a cardiovascular safety study done. And if these companies are going to do these studies anyway, you might as well look to see, gee, not only are they safe in type 2 diabetes, are they actually effective? They actually improve outcomes in type 2 diabetes. So we have a number that have been published to date, but there are way, way more out there that are yet to be published. And so the question then from these studies is you know, do diabetic drugs by themselves reduce cardiovascular risk? And apparently the answer is yes. We now have several drugs that are FDA approved for reducing cardiovascular risk in patients with type 2 diabetes, including several SGLT2 drugs and at least one GLP-1 drug. We're still a bit on the fence about whether Victoza, it's all drugs in the GLP-1 class or just Victoza. But the bottom line is that yes, we have several drugs now that, in addition to lowering blood sugar, seem to improve cardiovascular risk. What is that based on? Several big studies. The first was the Canvas study published in 2017. And we don't have the time to go through it in great detail, but they had about 10,000 patients with type 2 diabetes. They had to be 30 years old or older with a history of atherosclerotic cardiovascular disease, or 50 years older with 2+ cardiovascular risk factors. They were randomized to canagliflozin or placebo, and they found, again, when you looked at MI, stroke, and cardiovascular death, it reduced all of those by about 14%. And so they wanted to see if it was just as good as, and it was, as placebo. They wanted to see if it was as safe as placebo. They actually found it was way better than placebo. And in patients with cardiovascular risk reduction, it was about 18%. So bottom line was, yes, canagliflozin had a benefit that went beyond its ability to lower blood sugar. Empagliflozin in the EMPA-REG study found basically the same thing. 7,000 patients with type 2 diabetes, or adults who had a BMI of less than 45 and a GFR of greater than 30, and unfortunately none of these drugs are approved in patients with low GFR yet. And they were randomized to empagliflozin 2010 or placebo, and it also found a reduced risk of death from MI or cardiovascular causes by 13% and reduced hospitalizations for heart failure by 35%. So not only it seems to help even with heart failure patients. And then liraglutide or Victoza, the LEADER study in 2016, about 9,300 patients with type 2 diabetes, similar to what we've just talked about before, also finding a decrease in cardiovascular death, and this one caused a decrease in all-cause mortality by 15%. So it seems that, yes, we do have several classes of drugs that now seem to maybe be indicated in high-risk patients with known cardiovascular disease or many cardiovascular risk factors who have type 2 diabetes. Now, before we start prescribing them in everybody, some things to keep in mind. One, they're expensive, very expensive, so keep that in mind. Two, they do have some considerations with them. The SGLT2 drugs have an FDA black box warning for increased risk of amputation. And actually, the hazard ratio was almost 2, so you're almost twice as likely to have an amputation in the Canvas study compared to a placebo in that trial. Now, other studies have not found that, and so it's still kind of up in the air about is this really a causal relationship, and if so, how much? But it's something to keep in mind. There also was an additive part to that black box warning for foreigner's gangrene in men who have type 2 diabetes, and the theory is that, again, when your sugar is so full of urine's so full of sugar, if you're not cleaning yourself up properly in that area, you're probably putting yourself at risk for infection there. I know that foreigner's gangrene is, as I tell my students, one of my top 10 diseases never to get. So, you know, that joke tends to go better when I give it to pharmacists. That's okay. And then I say, currently, these drugs are contraindicated in patients with creatinine clearances less than 30. However, as nephrologists in the room know, there's emerging evidence suggests that these drugs, in addition to their cardiovascular benefit, may have a benefit in protecting the kidneys in patients with diabetes, and maybe even not without diabetes. That anyone who has proteinuria kidney disease, they may have a benefit for. And then the GLP-1 drugs do have a black box warning for thyroid cancer, and that has been shown as a possible relationship in several studies. So you want to avoid use in patients with a personal or family history of thyroid cancer. Not all, and what about our older drugs? Well, you know, we really don't know because, again, these older drugs didn't have to go through these cardiovascular safety studies. Some older studies with the sulfonylurea suggested that sulfonylureas may worsen cardiovascular outcomes, but with none of the drugs that we use today, so it's hard to see if that really is true. And then the TZDs, again, there's a black box warning for increased risk of heart failure with both of the ones that are on the market. So basically, it's, in 2019, how do you kind of approach patients who have cardiovascular disease, diabetes, or at high risk for such? Well, how are you going to kind of approach them? Well, first, the thing is can they afford these medications? Obviously, that's going to be the first and foremost thing. But if things aren't cost prohibitive, then I think we can kind of take a look at some of these other medications. So if you've got, metformin's still going to be first-line therapy. It's always going to be first-line therapy. It does decrease myocardial infarction risk based on the UK PDS study done back in the 1990s. We know it works. It's cheap. It's effective, right? Sulfonylureas, they say if you have known cardiovascular disease, you should not use those medications, not because they're harmful, but because we have other drugs that are also beneficial that we just don't know about the sulfonylureas. But again, many people just can't afford them, and so if it's cost prohibitive, you're going to have to use sulfonylureas. The GLP-1 drugs, they say you should consider liraglutide early, especially in obese patients. The DPP-4 inhibitors, you should avoid saxagliptin in heart failure, but it doesn't seem like any of these others have any benefit or harm in patients with cardiovascular disease. And then the SGLT drugs, again, across the board, decreases in cardiovascular death, cardiovascular disease, and all-cause mortality, and they say you should consider early in these patients. So I think there's definitely been a shift in patients with known cardiovascular disease to see if we can get them to afford and tolerate GLP-1 drugs and SGLT drugs because of their benefit beyond decreasing blood glucose. Okay, Gamechanger 5. The updated Beers criteria, and as much as I wish, I'm not talking about that kind of Beers list, unfortunately. So many of you know what the Beers criteria is. It's a list of potentially inappropriate medications for use in older adults. It was published originally in 1991 by Mark Beers, a late geriatrician who basically designed it, and it was published by the American Geriatric Society. And it is, again, a list of potentially inappropriate medications. I want to stress that because what's kind of happened with the Beers list in the last kind of 25 years is that large organizations have largely said, hey, here's a list of medications that we can use and compare in patients who are elderly and say, you shouldn't be on these medications for any reason, ever. And we're going to punish organizations, we're going to punish prescribers who use these medications because it's not up to where the quality should be, right? And I don't think that's what the Beers criteria was ever designed to do. It was assigned to list potentially inappropriate medications, right? There are certainly patients who may benefit, and I think it's supposed to heighten the awareness of the benefit and risk of these medications in patients over age 65. That's really all it's designed to do. So in 2018, there's an updated list. We certainly aren't going to go through the whole thing because of time, but here's some key changes. One is they've added glimepiride to sulfonylureas to avoid, and they actually say in the text to try and avoid sulfonylureas in the elderly if at all possible. Again, in patients who are elderly with type 2 diabetes, they may not be able to afford anything else. What I usually tell my providers is that if you're going to pick a sulfonylurea in type 2 diabetes, really for any reason, pick glipizide. It doesn't have active metabolites, so it's probably going to be the safest one in patients with renal insufficiency or elderly because they'll be less likely to clear it. That being said, I have seen profound hypoglycemia in elders who take sulfonylureas and then forget to eat or whatever reason. They add SNRIs to patients with a history of falls or fractures, and that's because they found one study that found there was an increased risk of both falls and fractures compared to other antidepressants. We won't belabor the aspirin for primary prevention, but they basically said, maybe use caution if you're going to recommend that. Rivaroxaban for the treatment of VTE or atrial fib in patients over age 75, they warn about because of the increased risk of GI bleeding compared to warfarin and other NOACs, and we've got a game changer about that coming up. They talk about the DPP-4 inhibitors in patients with heart failure, as we've just talked about, and then tramadol is actually added to the list of drugs that causes the syndrome of inappropriate antidiuretic hormone or hyponatremia. They also really beat up on cotrimoxazole just because they note that multiple studies show that the risk of hyperkalemia and acute kidney injury is higher in patients over age 65 who receive this drug. And they basically just say, again, don't use it, just use it in caution, especially if they're on other drugs that increase the risk of hyperkalemia, like ACE inhibitors, like potassium supplements, things like that. And then they talk about a whole bunch of combinations like the opioids and the benzos, the opioids and the gabapentinoids, and just basically note that we've got a lot of drug interactions going on that we need to be warned about. And the one I really want to focus on here is gabapentinoids and these patients. As we all know, the rise of gabapentin and pregabalin has fallen right in line with the opioid epidemic, right? So we can't prescribe opioids anymore, so we're just going to throw gabapentin and pregabalin at everybody. And I would caution people that the data that supports the use of gabapentin for non-neuropathic pain is almost non-existent, you know. And so keep that in mind. And the thought, well, we're not really hurting patients. That may not necessarily be true. This is a paper that just came out a few months ago in the Annals of Internal Medicine that looked at the risk of a pregabalin on patients also on opioids. In a nested case control study, they looked at 1,400 patients who had a fatal opioid overdose and matched with about 6,000 controls, and found that if they were on concomitant pregabalin or more than 300 milligrams of pregabalin, it increased the odds ratio of overdose significantly by 68% for any pregabalin use, and then high dose of pregabalin by 250%. So keep that in mind, that gabapentinoids in and of themselves may carry some risk, especially in patients on concomitant opioids. So there's some kind of general guidelines about how to dose gabapentin and pregabalin in patients in the elderly. I'm not going to go through this, but I think the whole maxim of starting low and going slow is definitely the way to go with gabapentin and pregabalin in the elderly. So that's what I just said, start low and go slow, right? For time, I'm going to kind of skip on to deprescribing. The other thing that the Beers guideline criteria talk about is the notion of deprescribing, which is something I think we're going to see more and more of in the literature in the next 10 or 15 years, which is defined as the systematic process of identifying and discontinuing drugs in instances where the existing or potential arms outweigh existing or potential benefits. And it all falls into this context of patients' current level of functioning, their life expectancy, values, and preferences. And I think this should really be considered, especially in your elders. When you're seeing your patients over age 80, over age 85, and you're taking a look at them and you're like, gee, you know, you've got, you know, multiple medications, you have some frailty, you may be on some drugs that are at high risk. Should we just take a look at all your medications and say, do you really need to be on all these things? For example, do you need to be on a lidronate in patients who've been on a lidronate for over 5 years? In most cases, the answer is no. The FLEX study showed really no benefit of being on a lidronate for more than 5 years unless you're on concomitant steroids. So I would say probably not, right? Statins for primary prevention. A paper in the Annals of Internal Medicine came out a couple years ago that looked at stopping statins in patients over age 75 and found no harm to them, and actually they found quality of life improved. So I think, again, as pharmacists and prescribers, I think we need to kind of sit down and say, you know, do these people need to be on all these medications? So the joke I make to my residents on students is, you know, we'll have some 98-year-old little old lady who's admitted for XYZ problem, and she's still on an aspirin a day. It's like, you know, you really need to be on an aspirin a day at 98? I mean, you win. You know, you have long outlived what the average human is supposed to live. I don't think you need to be on an aspirin a day anymore, or a multivitamin a day anymore. You know, so again, you know, try and do it systematically. You know, we encourage the pharmacists, you know, when we talk about them, is to bring all the prescription and non-prescription medications, look at what the indications for each drug is. Unfortunately, many times patients don't even remember why they're taking medications. Are they actually taking it? You'd be surprised how many times people think they're taking it, they're not. And does the benefit outweigh the harm? All right, Gamechanger 6 is another big one. The 2018 CHEST guidelines for antithrombotic therapy and atrial fibrillation came out. So we'll talk a little bit about that. Now, for those of you who've done a lot with anticoagulation, remember that in the old days, the CHEST guidelines came out every 3 or 4 years, and it was this big, huge tome, like it was like 1,200 pages long, and it was just basically the Bible of antithrombotic therapy. If it had to do with bleeding, it was in here someplace, right? So every 3 or 4 years, I would buy the CHEST guidelines because I would use them so much, it didn't make any sense to like borrow them from the library or something. So I just bought them and kept them in my library because I got so many questions about it. But now, like other medicine groups, the group at CHEST has said, no, we're just going to do what everybody else does and come up with periodic guidelines. And they felt that new guidelines for antithrombotics and atrial fib were needed because of the rise of NOACs, right, and the data surrounding their use. And so that's what we're going to kind of talk about here. Methodology was similar to the IDSA guidelines that we talked about. So it was a clinical question-answer format. They did a systematic review and took a look at the literature and then rated the evidence for high and low. And they basically just expert opinion was given a lower priority, basically. So they as far as the grades, like grade 1, benefits clearly outweigh the risk, and it's the strongest recommendation. And then the methodologic quality were combined in a final score. So here's some key recommendations for pharmacists and prescribers. The first is when you have somebody with atrial fibrillation and you're considering antithrombotic therapy, you need to use some scoring systems. You need to use scoring systems to look at the risk for stroke, and you need to use scoring systems to look at risk for bleed. And what they recommend in the guidelines is the CHADS-VAS2 score, as well as the HAS-BLED scoring systems to assess both benefit and risk of antithrombotic therapy, okay? For those of you who don't want to sit down and figure out all that stuff by yourself, there is a tremendous website out there called the SPARC tool, SPARCTOOL.com. And literally, if you just punch in the patient's risk factors, it'll not only calculate the CHADS-VAS2 and the HAS-BLED, It'll go through every iteration of what you could do with the patient for antithrombotic therapy and calculate number needed to risk and number needed to harm. So if you do nothing, what's the risk of having a stroke? If you put them on Coumadin, if you put them on a NOAC, it does the whole 9 yards for you. Very powerful tool that my prescribers use all the time for their own health calculations, but I think as much to talk to families and patients and saying, here's your, let's do some shared decision making. Here's your risk for bleed and here's your risk for stroke. And they do note that most of the time the risk for bleed is usually lower than the risk for stroke, even in patients with relatively high has bled score. So keep that in mind. The next big thing, and I've really tried to pound this home with my prescribers, aspirin for atrial fib is gone. Okay. Aspirin has no role in the treatment of stroke or prevention of stroke in patients with atrial fibrillation. Why? Because there was only one study that ever found that it worked, the SPAF1 study that was done back in the 1980s. No studies have been able to replicate that, okay? And I think what happens is prescribers think, well, I got this little lady, she falls a lot, I really don't want to put her on an antithrombotic, but I don't want her to not be completely covered, so I'll put her on an aspirin a day. You know, the studies show your risk of head bleed with aspirin is almost as high as it is with Coumadin. So not only are you not benefiting them for the stroke, you're actually harming them. So either go or don't go, right? Aspirin treats us, it really doesn't treat the patient, is basically what I'm saying. They do note that NOACs are now preferred over warfarin for atrial fib. Why is that? Because generally, all the NOACs have been found to be at least as efficacious as warfarin in preventing stroke and atrial fibrillation, and pretty much across the board, a decreased risk of intracranial hemorrhage and fatal bleeding. GI bleeding is a little higher with some of them versus other of them, but intracranial hemorrhage, which is I think the thing we're most worried about with these drugs, is lower with the NOACs compared to warfarin. If you're going to be on warfarin, they do recommend trying to get the patient into a time and therapeutic range of 70%. I can tell you that if you've ever worked in an anticoagulation clinic, that's difficult to achieve, but you can certainly try to do that. And then they also note the fact that in patients who have been, for example, on an aspirin a day for secondary prevention of an MI, and now you diagnose atrial fibrillation in them and say, hey, it's time to put you on a NOAC or warfarin, you can stop the aspirin. And multiple studies have shown that. There's no harm associated with stopping the aspirin, and they actually get the cardiovascular benefit with the antithrombotic as well. Warfarin was actually studied in the 1970s and 80s for heart attacks, and it worked. It just had bleeds that were super, super high associated with it. So it isn't like these drugs don't work for cardiovascular disease, they do. If you have a patient who absolutely has to be on that, they do recommend adding a proton pump inhibitor to minimize gastropathy. When do you, in a patient who's had an ischemic stroke and now you determine they have atrial fibrillation, when should you start anticoagulation? Because we're always scared about it being transformed into a hemorrhagic stroke. They say usually within 2 weeks of the stroke, but they don't really know when, and so they don't know the exact time. They say you should probably start within 2 weeks of therapy. Some studies have suggested somewhere in the 5 day to 2 week range certainly makes sense. And then in patients with chronic kidney disease, and just yesterday I see the Annals of Internal Medicine published a meta-analysis and systematic review on this subject. Are NOACs safe in patients with severe chronic kidney disease? And they don't really contradict what these recommendations are. They basically say that if you have stage 3 chronic kidney disease, you can use anything. In stage 4 chronic kidney disease, you can use warfarin or selected NOACs at a reduced dose. But for stage 5 chronic kidney disease, so people with creatinine clearances less than 15 mils a minute or dialysis, they should probably be on warfarin. Warfarin is we have the most data with that, and that's probably what they should be on. So the bottom line, some big changes with atrial fibrillation, and try and be familiar with these. Again, I think the big ones are NOACs are probably preferred. Aspirin is probably gone now for the prevention of stroke and atrial fibrillation. Okay, we're running out of time, so I'm going to skip this one and go to this one because I got a special request for it. So we're going to wrap up talking about serotonin syndrome. So I get this question a lot. I suspect the pharmacists in the room get this question a lot. Gee, my patient's on this drug and this drug, what's the risk for serotonin syndrome? And what I found over the years is that a lot of healthcare providers don't really even understand what serotonin syndrome is. They just read about it and think, oh, it's this terrible thing that can kill my patients, and I just want to make sure it doesn't happen. Serotonin syndrome is defined as a potentially life-threatening syndrome caused by high excessive serotonin stimulation. And it can be life-threatening. That's absolutely true. In fact, for the younger physicians in the audience, the reason that your duty hours were significantly reduced compared to your more veteran partners was the Libby Zion case. Anyone remember that case? The Libby Zion case was a resident who in the East Coast who had a patient on an MAOI. The resident hadn't slept in 2 or 3 days, saw the patient in the emergency room. They had a headache or some problem. They got Demerol. It caused serotonin syndrome and killed the patient. And the resident said, hey, I hadn't slept in 3 days. I didn't know what was going on, stuff like that. And so that was actually the first harbinger in the duty hour reforms that are now pretty common. Unfortunately, I think that serotonin syndrome is often misattributed or misdiagnosed, right? I have a patient who says when they take Prozac that they get a headache, so they must get serotonin syndrome. That's not serotonin syndrome, okay? Given the millions of patients on pro-serotonergic drugs, let's be totally honest. If serotonin syndrome was at all common, people would be dropping in the streets from it. But they don't, right? I can say, I've been a pharmacist for 28 years now, I think I've seen 2 real cases of severe serotonin syndrome. And everybody's on SSRIs, SNRIs, all these other medications. So it is fairly rare. Now, that being said, you might see it. And so there is specific diagnostic criteria called the Hunter's criteria. We're going to go through that really quick. I also want to point out that people can have serotonergic side effects, headache, jitteriousness, nervousness, akathisia, stuff like that. That's not the same thing as serotonin syndrome. That may be side effects, and they may not be able to tolerate it, and they may have to be off the drug from it, but they didn't have serotonin syndrome. Okay, what is the diagnostic criteria for serotonin syndrome? This is a nice algorithm that was in a great paper that in the New England Journal of Medicine that came out, it's been over a decade now. But basically, here's how you go through it to see if the patient has serotonin syndrome. Has the serotonergic agent been administered in the past 5 weeks? If not, obviously not. If they have, do they have any of these symptoms? And this is the Hunter criteria. And the biggie, clonus. If they have clonus, particularly ocular clonus, in fact, they say ocular clonus is almost a dead giveaway for serotonin syndrome, okay? But clonus is what you're really going to be looking at. Other things you're going to see, muscle rigidity, fever, and then tremor, hyperreflexia, and diaphoresis are all things. But if they have some combination of those symptoms, then yes, you do have serotonin syndrome. The other thing is that they may be on other medications that may have serotonin syndrome-like features, right? So when we talk about related clinical conditions, you can kind of fold serotonin syndrome into neuroleptic malignant syndrome, malignant hyperthermia, anticholinergic toxicity, things like that. And there's some things to keep in mind, but I think the key piece there is that serotonin syndrome patients have clonus, and that's, I think, one of the big things you want to look for, whereas neuroleptic malignant syndrome, they have lead pipe rigidity, which I've seen a few times, and I'm sure many of you in the audience have as well. And they do literally, like, you cannot move their arm. It's interesting to see, and they usually have a sky-high fever, right? And so those are some things when I'm trying to kind of figure out what's going on, those are some things that you want to take a look at when you're dealing with serotonin syndrome. How do you treat it? It's mostly supportive therapy. Even in the ICU, if they're super sick, we just stop their serotonergic medications. If it's mild serotonin syndrome, we just wait for the drug to wear off, and it's usually fine. But if it's moderate severe, they may need fluids because they're having fevers, temperature control, and then tremor, clonus, stuff like that. We'll add benzos. That's really it. There is no known specific antidote for serotonin syndrome. However, many experts still say that it's okay to use cyproheptadine. Cyproheptadine is a serotonergic antagonist, and it's actually in Europe, it's over the counter as an antihistamine. So it's a relatively safe drug. It doesn't really have any bad side effects, and it's really cheap. So when my residents come to me and say, hey, I think I have a patient with serotonin syndrome, the first thing I say is, well, do they really? Have we done the Hunter criteria on them to make sure they have serotonin syndrome? But if they're like, well, I'm pretty sure, should I use cyproheptadine? My opinion has always been, okay, well, I can't hurt them. If they can swallow or we can get it down an NG tube, I'm actually okay with it. But there's really no data showing that it helps. So, sorry, I'm a little late. I apologize, but it's a lot of information. It's a lot of information. I know I've kind of vomited up on you. I apologize for that. But, as always, if you can take kind of one pearl from each of these things kind of away to your practice and say, hey, this is kind of the way to go, and certainly if you have questions, get in touch with me. I'm certainly happy to talk about these things and give you that. And then, I always ask for feedback. What do you guys think would be a good, good game changer for the next year? I mean, there's, new studies, new drugs, new stuff. I actually had the chief of neurology corner me 2 days ago, and he wants one of these game changers to be, he's seen 2 patients develop new onset myasthenia gravis from these checkpoint drugs for cancer, which are now super common. And I went, okay, sure, sounds good to me. I mean, so we may be using that as a game changer next year. So we definitely take requests, is what I'm saying. Any questions? I'm happy to stick around after and talk to them. Please shoot me an email. Follow me on Twitter at New Wave Pharm. I promise only only medicine and music. I don't do any politics or anything on Twitter. So, questions?
I'm just wondering if you
Yeah.
could repeat that website.
The Spark website? Yeah, so SPARCTOOL. I wonder if I have internet access here. I might even be able to show y'all. I do have internet access here. So please work. I'm going to look like an idiot if it doesn't work. Okay, yep, here it is, right here. Spark tool. So then you literally just punch in. So here's their stroke risk. Let's say you have a 70-year-old female, who has a history of hypertension and diabetes, right? And let's say she has a history of hypertension. We'll just leave it at that. So her CHADS-VASc is 4, her HAS-BLED is 2. And a lot of calculators do that, but here's the cool part. Now you go to the bottom. If you don't do anything for this patient, her annual risk of stroke is 7.3%, annual risk. And her annual risk of bleed with no therapy is 0.37%. And then if you go to warfarin, it reduces that by 66% to 2.4%. Her chance of benefit, number needed to treat, is 1 in 20. And then risk of harm, where are we? 1 in 27 or 1 in 29. So, and then goes through all, it goes through even all the NOACs. So yeah, it's a very powerful tool that my physicians use all the time. So. Yes, ma'am. Oh, sorry, I thought you had a question. Yeah, I apologize for going over, guys. So, all right. Thank you very much.